Good afternoon, everybody. Thanks for coming today. Although I can't see you, I can see all the names on the screen, which is fantastic. So this is the first Health Innovation Network webinar, and today we're going to be looking at innovation insights relating to applying a health equity framework and addressing health inequalities. My name is MaryAnn Ferreux, and I'm the Chief Medical Officer at Health Innovation Kent, Surrey and Sussex. So thank you all for joining us today, and we'll get going. So this is a sort of a brief overview of our agenda today. I will be doing the introduction and setting the scene. And then I have some wonderful speakers who are supporting me today. Lucie will be talking about the 10 principles of health equity. We've got George, who'll be talking about our approach to health inequalities in Sussex. And then we've got Matt, who will be giving an example of a project he's been working on. And then we'll have about 10 or 15 minutes for some question and answers at the end. So we'll get into it. So I'm hoping that today's session will be useful to people, that you'll come away having learnt something from us. I mean, really critical from my perspective is that we have this broader understanding of health equity and how innovation can really address the social determinants of health. I hope that we can start to understand how we can use innovation to bridge those health inequality gaps in care delivery and access. I'm really hoping that you'll get some key actions that you can take away and which you can implement into your own practice to address inequitable health outcomes. And overall, this is really about fostering a culture of innovation and inclusivity in healthcare. I've seen a message come through about the slides being shared, and yes, absolutely, we'll make those available to you. So for those that aren't really aware of the Health Innovation Network or who we are or what we do, essentially we are the health innovation adoption experts. And what we're there to do is to support health and social care teams to find, test and implement new solutions at scale. And we've just put a few of our impacts at the bottom for you to look at in terms of the number of patients that have benefited and the amount of investment that's been leveraged and the jobs that have been created. We'll go to the next slide. So the Health Innovation Network, as the title suggests, is a network of a number of different organisations. So as you can see on the map of England, there are 15 of us. And my Health Innovation Network is Kent, Surrey and Sussex. So that's the region down in the southeast. And what's fantastic about us being in a network is that we're actually able to look at local problems and leverage some of that national expertise. But also we can look at national problems with a local understanding in terms of implementation and adoption. And the core purpose of the Health Innovation Network is really around driving economic growth in all parts of the country to ensure that everyone can benefit equitably from innovation. So just a little bit about my Health Innovation Network. So we cover Surrey Heartlands, Kent and Medway and Sussex integrated care systems. And it's really our vision to drive healthier and more equitable society by rapidly spreading innovation and connecting people to transformative ideas. We have, a very diverse population. We serve 4.7 million people across Kent, Surrey and Sussex. But like a lot of places in England, we've got lots of different problems from financial, operational and clinical pressures. So lots of issues around health and social care. And I think the big thing for us to think about today is that our populations are changing. They are becoming more diverse, they are aging. And people are needing access to the right healthcare at the right time now more than ever. So this is a little bit about our population health demographics in the southeast. Looking at this map, I thought it was a bit of a useful heat map for you to have a look at. It's a heat map looking at the multiple index of deprivation. And so the areas that are very dark red are the most socially deprived, and the lightest sort of yellow colour are the most affluent. The dots that are in blue are our GP practices, so you can see how they're spread across the map. And if you look really carefully, what you can see is that the areas with the most deprivation have the least number of GP practices. And I think that that's really telling you what some of our issues might be. And they relate to diverse populations, that relate to poverty, geography, a mix of these coastal communities. We've got rural areas which are significantly lacking in access to services, as well as, if you probably mapped on top of this access to public transport, you'd see something similar. So those rural and coastal communities are receiving a lot less care than our more affluent areas. And health inequity in England is costing the country a huge amount. So on this page are just a number of different examples around the evidence that there is. So when we start to think about health inequalities and ensuring health equity, we need to start moving it away from just being a moralistic argument and really start to make that case, the business case for change. We can't keep going as we are, because inequities are costing a huge amount to our economy in terms of lost productivity, and that's around 29.8 billion a year. So when thinking about the difference between equality and equity, it's important to look at it in these terms. So I just put this here as a infographic to try to explain what we mean in terms of equality versus equity. So in the first picture, you've got equality. So you've got 3 children stood on 3 boxes of the same size, but only 2 of the children can see the game. So that's equality. That's the assumption that everybody has the same. In equity, we're actually looking at everyone getting the support that they need. So the smallest child has the most boxes, and the tallest child doesn't have a box at all, and now they can all see the game. Social justice is completely removing the barriers that exist so that everybody can watch the game. But our reality, and particularly our reality in the NHS, is that those with the least, those who need the least get the most, and those that need the most get the least. So as you can see, our reality is that the smallest child absolutely gets the least, and the tallest child keeps on getting more. And that's what we call the inverse care law. So the social determinants of health are really important for us to understand in the context of us talking about health inequalities. And we know that there are a number of different factors that impact on a person's health. So we have socioeconomic factors, and they account for about 40% of those determinants. And there are things like somebody's education, what job they might have, how much income they might have, where they live. 10% is incorporated from your physical environment, and 30% are related to health behaviours. So, and they're things like diet and exercise, it might be tobacco use, drinking alcohol. And in fact, healthcare provision only accounts for 20% of somebody's health. So in total, 80% of what makes up somebody's health is determined by what happens outside of healthcare. So that's really important for us to remember when we want to think about innovations to address health inequalities. Another area that I think is important just to mention here is about intersectionality. And you might have heard this type of term before. This infographic is actually from NHS England, and I thought it was a really good one to just for people to understand what we mean by intersectionality. So it includes multiple layers of factors. So those people who might have protected characteristics like age, gender, disability, those who might live in socioeconomically deprived areas. So that could be those who have live in poor areas, don't have employment, have poor housing. Those that geographically might live in urban, rural or coastal communities, or those who are from inclusion health groups. And in particular, we're talking about sort of vulnerable health groups of Roma Gypsy traveller people, people experiencing homelessness, or refugee and migrant groups. And what it is that you may well come across patients who, or individuals that have one of these areas impacting their health, but you'll also come across people that have multiple levels of social disadvantage that is driving their health and their behaviours. So, for example, I might be dealing with a patient who is an older Black woman who lives in a rural area, who's unemployed, and has been experiencing homelessness for the last 3 months. So those overlapping layers of disadvantage can really impact on what that individual's health journey might be. And so again, that's just something for us to think about when we're talking about health equity, addressing innovation, addressing health equity. So when we're looking at the challenge of health equity, what I really just want to get across to you is that what we're talking about is it's a really broad and complex issue. It's connected to all aspects of health, and therefore it really requires a holistic and integrated approach and real attention in terms of our decision making. But the positive is that it is actually preventable and avoidable, and therefore actionable. So before we just get into the 10 principles of health equity, which my lovely colleague Lucie is going to present, I can see there are a number of different messages in the chat about people not being able to see the slides. Have we been able to fix that? I might just bring in Annie or Megan. Yes, I can see.
I've just shared through a different method, so hopefully people will be able to see those now.
Can we see, can people put their hands up? Yes, fantastic. Okay, we can also make these slides available for, fab. We can also make these slides available for everybody afterwards. You're not going to miss out on anything. We can send them through to you. So my wonderful colleague Lucie is now going to present the kind of meat of this webinar, which are the 10 principles of health equity. So over to you, Lucie.
Thank you, MaryAnn. So yes, I'll be talking through the 10 principles of health equity, which we at Health Innovation Care Assess have developed. I say we, MaryAnn, using latest evidence and best practice. So MaryAnn set out really how addressing health inequalities and promoting health equity is complex and takes collective, multiple faceted approaches to be effectively to promote health equity. So we've developed these 10 principles, and I'll talk through each of these just to give a bit of an overview of what they each entail and kind of food for thought. So if we go on to the people principle, so that's really about understanding which population groups will be impacted most by an innovation or an intervention, but also which communities an innovation can also support. So that will include considering the general population, but also which communities will face additional barriers and challenges in accessing or using an innovation, and where health inequalities are most pronounced. So as MaryAnn's kind of mentioned, it's also important to consider that overlapping disadvantage and understanding kind of interventions and approaches that can help mitigate multiple challenges when designing and implementing innovations and solutions. So when working through this principle, you'll want to understand what kinds of inequalities each group will face, and how the solution can mitigate barriers and challenges and reduce health inequalities rather than exacerbating these. So with data, this can really be utilised to explore those population health differences and understand inequitable health distributions. So considering factors such as age, gender, ethnicity, and deprivation. And through this, we can uncover patterns that highlight where disparities exist and understand which populations to focus solutions on, and also where additional support may be needed. And through linking databases, this will enable a comprehensive assessment of intersectional factors and provide insights into how multiple forms of disadvantage intersect and can compound health outcomes. This will then inform strategies which may need to be targeted so that they'll be more equitable and effective. And data can also be used in evaluation to measure impacts, both in terms of health outcomes, where health inequalities are being addressed, but also to understand wider social value and impacts and broader societal benefits. So care is really about co-production, which is really the cornerstone in developing impactful health innovations that truly meet the needs of people. So by working collaboratively with service users and community groups, we can ensure that new solutions are grounded in lived experience and create services that meet the unique needs of disadvantaged and vulnerable communities. So through inclusive approaches, this helps build trust and can lead to more sustainable outcomes, but also increased chances of successful implementation. So when promoting self-management tools, this can also help empower individuals who can take control of their health in ways that work for them. And evidence has indicated that when people are actively involved in shaping and managing their care, this also has an impact on positively improving health outcomes. And gains can further be made by initiating strong intersectoral partnerships through bringing together healthcare providers, community organisations, innovators and policymakers. And these collaborations enable a multifaceted and holistic approach that can help strengthen solutions, accelerate adoption and support implementation. So clinical is about engaging the clinical workforce and understanding what the challenges are on the front line, how the workforce may be impacted by a change, and understanding how a solution will fit within existing pathways and services. So an important part of clinical engagement is ensuring cultural safety within clinical pathways and decision making. And this means creating environments where diverse values, beliefs and needs are respected and integrated into service delivery. And that will in turn enable staff to provide inclusive and person-centred care. So through identifying and empowering teams, this will champion implementation and inspire others who will lead change and drive innovation from within. So with digital solutions, they're transforming healthcare, as we know, and are contributing towards improving access and personalising care, but also streamlining services. But there is a risk that innovations can exacerbate health inequalities. So it's really important to think about digital exclusion and inclusion. So to make the most of digital technology, we need to identify groups at risk of digital exclusion. And these will likely be older adults, people with disabilities, those on low income, or individuals with limited access to the internet. Digital literacy skills also play a role, and it's important to understand where additional support and training are needed. But importantly, co-production, again, is really essential in designing digital solutions. So if we design digital solutions with the most vulnerable in mind, This will then ensure those digital tools are accessible, user-friendly, but importantly, relevant to all. So when implementing them, that should increase chances of people being able to access them and mitigate against those inequalities. So finance is about considering the needs of those in financial hardship, but also demonstrating the benefits of a new solution in terms of sustainability and return on investment. So we have a backdrop of the cost of living crisis. So those experiencing financial hardship are having to make really tough choices around what they spend their money on. And if they have to pay for travel costs or parking or prescriptions, or even to take time off work to attend an appointment, this will likely be a barrier for them to attend care that they need, so appointments or picking up prescriptions. So when developing and implementing solutions, it's important to consider ways in which financial barriers could be mitigated. So that might be through offering telehealth or at-home testing options, or covering prescription costs. And again, through evaluation, we can build measures in terms of return on investment and wider benefits. And that will really make the case for sustainability of new solutions or services, but also promote longer term, sustainability. And place. So this really considers the wider infrastructure. And again, linking back to MaryAnn's presentation on rural and coastal locations, these have a significant role to play in terms of barriers, where people can face additional barriers in terms of accessing care, having to travel for longer periods of time, or having broken kind of transport links, or not as effective transport links. So working in partnership with local organisations, we could provide local health checks, for example, in community settings, and help mitigate against those kind of barriers and improve uptake and diagnoses earlier, which will then in turn improve health outcomes. And again, kind of working with co-production in partnership is really key. So climate relates to considering the challenges communities may face who are more susceptible to climate change. So that could be extreme weather, flooding, or receding coastlines. And again, certain groups in communities will be most at risk, such as older people, babies and children, and those with pre-existing conditions. And this principle also encourages us to consider how we can contribute towards meeting the NHS net zero ambitions, and how climate change could impact on your business model and any steps that can be taken to ensure sustainability. So we do have an innovator guide to net zero, which we can signpost to, and that's a really useful resource for thinking through these challenges. Okay, and policy is around addressing bias in health policy in order to achieve fairer and more inclusive outcomes. So we need to work towards addressing both present and systemic wider historical barriers that continue to exacerbate health inequities. So we can start off by reviewing our own policies and procedures, and they may unintentionally disadvantage certain groups, and we can work to debias these, as well as ensuring we have effective EDI policies and procedures in place. So to do this effectively, we must ensure that diverse voices are included in decision making, which can be achieved through bringing in lived experiences and community perspectives that are often overlooked. And these also ought to be embedded within commissioning processes to ensure services are meeting the needs of all populations. And we also do have a Commissioner's Guide for Health Equity that we can signpost to, which is around promoting health equity for commissioners in decision-making processes. So finally, communications. This is about inclusive messaging, which helps ensure everyone can access, understand, and act on important health information. So it's really important to actively engage communities in developing comms to ensure that messages you're wishing to convey are being effectively heard and understood. So we should explore alternative and inclusive messaging formats also, such as through visuals, audio, or digital tools, and also text to speech. So we can make sure we're reaching people with different needs and preferences. So this broadens our communication impact and helps break down those barriers. And ultimately, inclusive messaging supports better health, education, and prevention, and empowers individuals to make informed choices about their well-being. Okay, I think those are the 10 principles.
Thanks so much, Lucy. And so for those that would like some further support, this is a QR code. Get your phones out, scan it. It's our Innovator Guide to Health Equity. It's free, it's available, and it will take you again through those 10 principles. There's a bit of an assessment there that you can do as well. So I hope that you find that resource useful. So what would I like you to go away with? So my kind of 5 top tips that I'd really like you to take away. So the first is around, if you don't make it a strategic business priority, it's not going to happen. So health equity absolutely needs to be embedded in your strategic planning to actually make change happen. The second one is that we really need to ensure that we're being inclusive. And the major one here is around addressing digital exclusion. As Lucie so wonderfully put, we take it for granted how privileged we are, you know, that we've A, even got a phone, B, we know how to use it, C, we've actually got, you know, we've got data and we've got money to pay for that access as well. But there are many people out there that don't. And so how we can ensure that they're included in our plans is absolutely critical to ensuring health equity for the future. The third one is around innovation. I really think and believe that innovation has an enormous part to play in addressing some of the wicked issues, particularly around the multiple determinants of social determinants of health. And when we think about the complexities that sit within that, I absolutely think that innovation has this immense opportunity for good in the future. So really think creatively about how you know your innovation might address those wider social determinants. The fourth one is that we must eliminate bias, and in particular gender and racial bias, from tech and data. So we know that historically within research and clinical trials, women and people from ethnic minority backgrounds have not been recruited or included as part of the data. So if you're using a general data set, don't assume that everybody is included in that data. Really interrogate it and ensure that the data that you're using to test or develop your innovation on is actually representative of your population or community that you want to implement this into. So be really thoughtful in terms of looking at that. There's a huge amount of implicit bias that happens within the health tech sector. And so any ways in which we can address that you know, are really important to achieving health equity. And the last one that I'd like you to take away is that thing around co-design. So if we don't partner with the communities to develop new solutions, we're not really addressing the really important needs that are on the ground. So that's it for me, and I will hand over to George, who's going to tell you a little bit about some of the work that we're doing to address health inequalities in Sussex and about our Population Health Academy.
Thank you very much, MaryAnn, and that's a very neat segue to tell a story really about how we've been working together with Sussex Integrated Care System to make health equity a reality for the people that we serve. So as MaryAnn shared earlier, there is a uniqueness about our region, Kent, Surrey and Sussex. It's got a mix of urban, rural and coastal. So stay with me here for a bit. There's an aquatic theme here, but you know, for those who live by the coast and in particular Sussex, you know the power of the sea, right? It connects, it shapes and sometimes divides us. And health inequalities work in the same way. Some communities are riding the waves while others are left treading water. And our job really is to change the tide. Hashtag dad puns. But in all seriousness, there are three core elements really to this work. And if we're serious about shifting the tide on health inequalities, we need more than just one tool in the kit. This is why the Academy was set up as an infrastructure for change. So it's a tri-elemental academy that is looking at the online aspect of things. We talked about digital inclusion earlier. So this is a space where professionals across Sussex, whether they work in a local authority, whether they work in the NHS or the voluntary sector, can access training events and resources and connect with others tackling similar challenges. That's the first element. The second is the Health Equity Fellowship, which we'll talk about later. And we have one of our Cohort 1 fellows. It's a 9-month program developing equity leaders and equipping them to drive change from within their organizations. And whilst in 9 months, you could deliver a baby, it's not easy or often possible to deliver transformative change over 9 months, which is why the work continues even beyond the fellowship, and our fellows are demonstrating that. Thirdly, system-wide training. So there's a structured series of webinars and learning opportunities that we've helped set up, and they're designed really to embed population health principles into everyday practice and really make population health everybody's business. So these aren't just individual efforts. They work together to create a workforce that understands but also acts on health inequalities, so that progress isn't just a ripple but an actual wave. So looking at the capability, the capacity, and the confidence that needs to be built. Now, why? One of the favorite questions of that my children like to ask. And really, if you look at health outcomes across Sussex, you'll see a stark reality. And this is probably similar in many other areas across England and globally even. In some areas, people live healthier, longer lives. In other areas, often just a few miles down the road or the coast even, illness comes earlier, access to care is harder, as MaryAnn showed us in that heat map, and opportunities are fewer. So this is where the power of collaboration comes into its own and a whole systems approach. So working with Sussex, we realize that tackling health inequalities isn't just about throwing out lifeboats. I'm still sticking to the aquatic theme here. It's about changing the currents. So that's why the Academy has been built, to take a whole systems approach to embedding equity through workforce development, again in a form of capacity, capability, and confidence building, ultimately for transforming the lives of the people that we serve. Now, next slide tells us, or tells you a bit about the third element that I talked about earlier. So back in 2023, Sussex as a system undertook a survey. They asked their staff across the system what they would like to learn or what they know about population health, and a few other questions. And there were some really powerful insights. So a few punchlines. Many had or expressed that they had minimal knowledge of population health. There was a strong appetite to understand Sussex-specific health inequalities so they could address them more intelligently. They wanted to see what's working elsewhere as well, and apply best practice locally. And at the same time, staff were also saying, we want to do something about inequalities, but we don't have the time or the tools. So again, this is why the Academy exists. And to respond to that, a series of foundational webinars were co-curated with partners in Sussex and beyond to again, make population health everyone's business. So we started with a first webinar on explaining what population health is and demystifying it, a second webinar on sharing some tools for population health and looking at population health management, and a third webinar on examples from Sussex and beyond, so looking at case studies of where a population health approach has worked and the impact that has had. Now, we didn't stop there. So after year one, as you can see some of the numbers there, we had good participation and we wanted to build on that. We know that people don't just want another PowerPoint lecture, they want practical insights that they can use. So building on year one, our second year of webinars was focused on real world applications. So we covered a number of topics. So we're almost there. We've got one more webinar on the 26th of March, but we've covered a plethora of topics, including, from cultural competence in healthcare to quality improvement to using data for better health outcomes. And we're trying to make sure with the system that these aren't just abstract discussions, but they're shaping how health professionals actually embed equity into their daily work. And back to my aquatic analogy and looking at the Health Equity Fellowship, you don't learn to swim by just reading about swimming, you learn by getting in the water. And that's exactly how we've tried to design the fellowship, for it to be an immersive experience by name and by nature, but not quite. So we've ensured that as part of the recruitment process, when fellows are applying to become fellows, they are talking about a wicked issue or issues that they're trying to solve. So their fellowship is going to be grounded in an equity-focused project. So that's one element. We've got a combination of workshops and masterclasses in person and online to bring people together to problem solve. We've got action learning sets so fellows can learn by doing and by talking with each other and problem solving rather than just listening. And as well as doing that, having a network of change agents where people can drive equity from the inside out. And of course, some commitment. That's the capacity element in the 3 Cs. So as well as that, we have been able to recruit a number of people as our change agents. And these are not all of our fellows from our second cohort, but you can see here a mixture of organizations representing the system, a breadth of professions and disciplines as well, but also an interesting variety of projects. So our second cohort consists of 12 new fellows who are tackling some of the toughest inequalities in Sussex, from improving access to menopause care to reducing A&E pressures for high intensity users. And evidently the fellowship is growing. From 8 in our first cohort, we've got 12 in our second. And with every cohort, its impact hopefully multiplies, and you'll hear a bit more about that. And a quick whistle-stop tour of the impact and the story that we're trying to tell and what we've seen. So our next slide really has a QR code, so you can scan that to see what the projects that our cohort 1 fellows were, that they undertook, and what the impact was, and what their learning experiences have been as leaders. And the other QR code will take you to our Series 1 webinars, which are all on YouTube and accessible by scanning the QR code. So great that we have the volume in terms of participation and the variety in terms of the organizations represented, but it's even more impactful when we see the numbers and the narrative around the impact that is felt for the people that we serve in Sussex. Now, without further ado, so you don't just hear it from me, I'm going to pass the mic on to Matt, one of our cohort 1 health equity fellows in Sussex, who can tell you a bit about his project and his experience and the impact that's had. So over to you, Matt.
Thank you, George. Good afternoon, everybody. As I've already had my introduction done for me, I was a Sussex Population Health Equity Fellow in the first cohort in 2024. And at that time, I was working for the Sussex Community Foundation Trust as a digital nurse specialist. So working in digital services, obviously, the inequality I was trying to address was digital inclusion. In that sense, my project was a little bit different from some of my colleagues. I was not trying to gather any evidence. I was just trying to get on with it. In other words, we know the inequality is there. We know that we are at risk of exclusion when we digitize services. We know that we are in a drive to digitize the NHS as much as we can, and there is a possibility that we're going to leave people behind. That led us to the conclusion that we are probably likely to be building exclusion by design, and that needed systemic change, that needs addressing from the system. If you go to my first slide, please. You've already seen, and it's been talked about in some of the equity principles, that there is a digital divide. One of the main problems with this digital divide is that the social determinants of digital exclusion will overlap with other social health determinants, and it will make things worse. So we are likely to innovate with our services, make them digital, make them what we thought was more accessible and leave people behind. You see some numbers here. Essentially, the picture they paint is that there is a potential for lack of a number of things. I'm going to give you a link if I manage. I'm putting a link in the chat because all of these data is widely available. The Good Things Foundation has a good infographic to explain all of this, but essentially what we're trying to tackle here is not leaving people behind when we digitize services. There's a number that is staggering of people that don't have digital skills. It's 8.5 million as of latest estimates. Numbers obviously are not mine. This is Ofcom, Good Things Foundation, and these are the numbers that NHS England is working with. As well as the skills, there's a lot of people who don't have access to devices or data. So I'll leave it at that, but that gives you a picture that the divide is important. If we I'm not going to answer to all the questions, but yes, 8.5 million in this country. We're talking about, well, this country, the United Kingdom in general, not this country, England. So in terms of health, the people that are offline, a third say that they find it difficult to interact with NHS services, digitally or not. Our services are not the easiest to interact with. Of the people that are online, which is not on the slide, most people say that the NHS is one of the most difficult services to access digitally, and that gives us already an idea of where we have to head. We are banking very heavily on the use of some apps that are very well thought and very accessible, etc., like the NHS app, but still almost 4 in 10 UK adults are not registered to use the NHS app. So that would give you an idea that if we make our services more online, more virtual, more teleconsultation, we are going to lose at least that 39%. These are numbers that you can do what you do with numbers, and there's a lot of interpretation to be done, but the exclusion is obvious. So in that sense, I took these numbers as the evidence we needed and a call to action. If we could go to my next slide, please. And in terms of tackling digital exclusion, I was standing on the shoulders of giants already, based on the work done by Kath Sykes of Health Innovation, Surrey and Sussex, with the University of Sussex, who created the Digital Inclusion Framework. This is a toolkit that is now more or less adapted to an NHS England toolkit nationally. And my whole project started with, how do we implement this? It was a very simple question, like, how do we get a whole trust to start using this? Initially, the ICS did not see a particular problem with it. It's like, we're already using it, or that's what they thought. The toolkit covers a number of things when you purchase or implement a technology. It's considerations around access and affordability, the skills needed and what digital support is there, the trust of the population, usability, motivation, etc. So there's a number of moving pieces here, but the how we implement it led to the whole project that I undertook. If we go to my next slide, please. So the integrated care system thought they were using the framework, and for them it was relatively easy, because as a big commissioning group, you just purchase a big piece of technology, you apply the framework once, and you call it a day. That's inclusion done. The reality of the implementation of technology in the NHS is a lot different. Yes, procurement is a key point in terms of how inclusive our technology is. Giving you an example, if you procure technology that is not ready to be used with a screen reader, for example, for visually impaired people, there's no way you can retrofit it to be accessible for that. So you must be sure that your technical specifications when you buy something are correct. But then the way you implement it might change things. the way you train and who you train in the use of that technology, be it your staff or your population, the way it's maintained, the changes made in business as usual, how new services are transformed to incorporate these new technologies, how innovations are made in the use of different technologies by patients or not. There's examples everywhere, and I'm thinking of messaging services through different NHS apps that were approved and looked at from an inclusion perspective and regarded to be inclusive, were used in ways that were not predicted, like, for example, sending questionnaires to patients and discharging said patients if they didn't reply to a particular questionnaire, which assumed they had a smartphone, which assumed they had time, which assumed they spoke the language, which was very exclusive in itself. So how do we tackle all of this? And I'll start with that in my next slide. So if we look at the tools we have available, there is a number of standards used by the UK government and the NHS in general. There's a number of accessibility standards. You can look at a lot of these things in the NHS strategy for inclusion. I will paste the link in a second. There is, of course, the digital inclusion framework that I was speaking of. So there's the way we use our data and what data we collect. It was mentioned before, there's inherent bias in our stratification of population. There's inherent bias in our decision-making tools, and we cannot break this bias if we don't have the information or if we're collecting the wrong information. Surprisingly, when you look at how ethnicity data is collected in the NHS in general, a surprising amount of trust barely have any data that are workable in terms of ethnicity in their patient records. So this is an ongoing issue. So we have the tools. How we get a trust to use them, because if you ask any of the individual teams, like, could you just kindly please be accessible, a lot of the time they will say, like, how, when, who pays for it, what's my time, etc. So we need to create a strategy. And in this case, we needed to create a policy at trust level. And that takes me to my next slide. So on one hand, there's a, excuse me, there's a policy analysis scientific bit where we look at decision-making, intervention points, etc. That was the mapping. Then there's an approach based on the public policy making a process, which is very long and not going to get into here, but you need people to know that there's a problem. You need people to be sensitive to that problem. You have to find a window of opportunity and then create policy and regulate around it. In this case, we have the evidence presented in the right times at the right people creates visibility, creates sensitivity around the topic. The opportunity in this case was created by the inauguration of the new national policy around new national strategy from NHS England around digital inclusion. And of course, in my case, being part of this fellowship and having dedicated time. Nobody else had the time to do this. So through stakeholder engagement, meaning getting everybody mapped, who's a decision maker, from your medical directors to DEI to population health, all the digital actors, which are many. You need to create capacity. Those tools are not immediately explanatory. They are not so easy to use. Applying web content accessibility guidelines for coders are not something that is intuitive all the time. And how we get time to do all of those things. So in order to do all of this, you also need somebody working on it regularly. So as long story short, policy analysis, this is the problem, these are the stakeholders, these are the things we can do, this is the regulatory framework we're going to create. So my next slide, please. To cut a very long story short, essentially after all this process, we created our trust policy The slide says draft, but I'm happy to announce that it's been approved and ratified in the past 4 or 5 days. And that's a while after my fellowship was finished, but the work continues, as George said. Stakeholders are now embedded into different teams, into different decision-making processes. And now we have a digital inclusion group posed by it's a multidisciplinary group that is in charge of implementing this policy. The policy creates a number of things. Yes, we have to use accessibility standards, but also we want to use innovation to target interventions towards gaps that we detected, and we want to create specific ways of engaging with the population around this. All of those things are now in process because now we have the framework, now we have everybody working together in a coordinated effort, and I think that's how you exert systemic change.
Yeah. Thank you so much, Matt. That's it's great to hear your work, and it's a good example of you know, how challenging it can be to in terms of the implementation of a project, and hearing your insights and experience has been great. Just in the last few minutes, we will do some questions. So I think there are a couple that have come in the chat, and I think there's one around the SDE and the Q&A. Annie, which question shall we go with first?
Michael Mullen has a interesting question. What are your thoughts on how social media, health disinformation, things like algorithms that promote anti-vax and anti-inoculation bots are impacting health inequalities across the UK? And do you think there's anything that can be done to support social media, like tackling the social media from a legislation's perspective?
Yeah, it's a great question, and it is something that I talk about in other places quite frequently. So there are a number of different communities, and I think I can, you know, say that I've recently spoken to people from the Black and Afro-Caribbean community. Huge amount of distrust with establishment, particularly the NHS or establishment types organisations, mistrust of the system. And a lot of that is generated from online content. So I guess from my perspective, this is our reality. Social media is not going away anytime soon. But what is it that we need to do from a health system perspective to ensure that the right information is out there in terms of health education, health promotion, health prevention? And I think that we, in some ways, need to get with the times. So, you know, I'm really glad to see there are so many fantastic YouTube creators. So there is actually a health YouTube channel that has got certified clinicians on there. How can we promote that more? When we spoke to women in Sussex and we did our women's health report with Sussex ICB, we went and spoke to women of lots of different groups, and they said we would like to get some of our information from social media. And so it's somewhat for us who are working within the system to actually change what we're doing in terms of how we're communicating with individuals and communities. And I think that's something that we talk about in that communication section of the health equity framework. So I think we need to ultimately be more creative. I think we need to modernise what we're doing, and we need to combat that misinformation with the right information, because if we don't, somebody else will fill the void. Lucie, I might bring Lucie in. She might have some insights around that as well. She's done a lot of work around public health.
Just agree as well that it's just about, I suppose, countering the misinformation with correct information. But I suppose it's also where that comes from, because the NHS isn't necessarily cool amongst young people. I think that also came through in the women's health work. So having trusted advocates as well that can support with that. So utilising social media in the best possible way. But I know it's a continual battle. We were talking about this 10 years ago around junk food advertising and social media, and yeah, unfortunately in terms of legislation that's a really difficult one, but as we've said, we can only try and kind of counter it with better, more effective evidence-based information in ways that will resonate with those communities and populations.
Yeah, that's great, thank you.
Lovely. And then Catherine Houghton, she has just said, it's great to see these principles. Just to flag, local and wider public health teams will have a lot of data and assessments of needs that can help take a population health / data-led approach. So just for everybody to be aware.
Absolutely agree. We need to stop the silos. We must partner across all of the different organisations. So the NHS, I think, can sometimes be quite insular, and I think we need to really broaden how we look at health and care and really start to think of it from a patient individual perspective. How do they think we interact? And then start to do that sort of assessment. Are we actually interacting with each other how our patients would expect? And most of the time it's not. We aren't working like that, and we're not communicating like that. So we need to do more.
Just to add as well onto that, MaryAnn, in the Innovator Guide we have referenced resources such as joint strategic needs assessments, which are led by public health teams. So yeah, absolutely kind of utilising what's out there and bringing that forward.
And George?
Yeah, I was just going to add to that. Interestingly, when we ran our first series of webinars, we engaged with local authority teams, public health teams, for them to explain and share and demonstrate, even expose what some of the local challenges are because of those insights that they have. And also in terms of equipping people to take a population health intelligence approach, we had colleagues from OHID walking through Fingertips, a tool which we could probably post in the chat later on, and what it is and how it can be used to harness the data that exists already. So lots that is being done, but certainly more that can be done.
Yeah, we're not here to reinvent the wheel, but we are here to promote a much more collaborative approach to the challenges that we face across health and social care. Any other questions?
Yeah, so Kate's just come in with, do people who distrust NHS and other establishments give reasons for their view, and what can we learn from these reasons?
So I think there are, having spoken to some communities, there are lots of different reasons why they don't trust the system. Some of it is misinformation. Some of it is historical past abuses that have happened. So things around vaccines. There was obviously the huge scandal around syphilis for the Black community. And, you know, I think that those generational traumas can be quite profound, and a lot of what we need to do is actually really understand what are some of those barriers and challenges that those communities are facing. What is it that we can do to really listen to their issues and to provide care in a way that is supportive and holistic and integrated. George, I mean, I might bring you in on that subject as well, because I think you do a huge amount of community work, as well as your role at Health Innovation KSS.
Yeah, thanks, MaryAnn. Absolutely. Just back to the point around trust. I mean, it takes ages to build trust, but it takes just one faux pas, one incident, one misstep to completely ruin it. And as MaryAnn mentioned, I do some work in my local community as a governor, my local primary school, but also serve at an outreach Sunday school in Southeast London. And we certainly saw the impact that COVID had to the, I guess, engagement of our children and their families to the Sunday school because of the absence of devices, for example, lack of connectivity because families had to make decisions between buying data or buying food, or even you know, when we're launching Zoom classes, parents coming to us and saying, what in the world is Zoom? And making sure that we are addressing those three layers there, the access, the connectivity, and the confidence. So there could be multiple issues and multiple reasons and causes to the lack of engagement or mistrust. And a lot of it, as MaryAnn said, is trauma. So we need to be better we need to be trauma informed when we're designing a lot of these interventions, and I think there's a lot to be said for that skill and capability and insight.
Yeah, thank you so much, George. And we might leave it there because I know that we need to wrap up at past and we're 1 minute over. But thank you so much for joining us today. It's been a wonderful webinar. We do have another health innovation network, which is Oxford and Thames Valley, who will be doing the next Innovation Insights webinar, and theirs is on harnessing AI brain imaging to transform delivery of thrombectomy for stroke, and that will be on the 18th of March. So thank you again for your time today. Wishing you all the best. If you have any further questions, please send them through to us. We're happy to answer them offline through the email, and see you next time. Bye.